Good afternoon, chairpersons and friends, colleagues. We'll see how a child lives with artificial valves. I'll be focusing mainly on mitral and aortic valve replacement and not on pulmonary and tricuspid because their pulmonary is separate, it is a separate entity in itself. And once we replace these valves, it is more like a palliative procedure, just like a fontan, because they have complication, they need re-interventions. So the factors affecting mortality in these patients, the younger the child, a longer closed clamp time, underlying congenital disease, higher prosthetic size compared to the body surface area, whether they have a post-operative complications, they all contribute to higher mortality in the long run. And the 15-year survival rate after MVR is now 80%. A supraannular position has a higher incidence of complications. A smaller valve size also fares badly. And in general, a meta-analysis shows about 70 to 80% 10-year survival. In aortic valve position, the early mortality is up to 7%, which is about twice the adult population. Late mortality is also comparatively higher. And the younger age at operation for AVR also is poor prognostic factor. And tissue valves fare badly, as we know, compared to mechanical valves. So what we need to do is periodic imaging. For all mechanical valves, about 6 to 12 months of frequency of echocardiography imaging is necessary. Bioprosthetic valves require much more frequent imaging. And children are not adults. And we need to compromise on many aspects and tailor make all our modalities of either diagnostic or interventions to adjust to this situation, particular situation. They are to be on oral anticoagulants and aspirin. AVR, if they are low risk, they can be, AVR, if it is high risk, they need to be on 2.5 to 3.5 warfarin plus aspirin. MVR also similar. Low risk AVR can have lower degree of anticoagulation. Bioprosthetic valves, after 3 months of replacement, need not have oral anticoagulants. And the initiation and maintenance of warfarin is as per this chart, 0.2 milligram per kilogram to start with. And subsequently, based on the INR, the dosages has been recommended like this. Maintenance is also by each fraction depending on the INR. Monitoring should be once in 2 to 3 weeks initially as an outpatient, and once we reach a stable INR, once in 3 to 4 weeks. More frequent in infants and children, especially when there is change in the diet or medication, or if the child develops a vomiting or diarrhea, or if there is hepatic dysfunction, we need more frequent monitoring. Adverse effects are well known. No, challenges on warfarin in children, particularly dietary intake. And there are challenges in the absorption, is very unpredictable in many of these children. And venous access is a very difficult problem for a drug which has a narrow therapeutic index. And this develops anxiety in the parents as well, and needle phobia in children. Adjustment due to periodic illnesses, which is common to the children, particularly common cold, then we have to give antibiotic that will also affect these oral anticoagulants. And because of all these factors and in the complexity of the underlying conditions, they require more frequent INR monitoring compared to adults. These are the challenges we face in children after valve replacement. Particularly, intramuscular injections can be given, but NSAIDs should not be given without consultation. Contact sports should be avoided, but otherwise if the valve function is normal, normal activities can be done. If patients, children, particularly INR monitoring not possible, then they are not able to take warfarin, low dose aspirin is recommended as a class 1 indication. Rheumatic fever prophylaxis, of course, should be continued in patients with rheumatic heart disease. These are the side effects of aspirin, which we should bear in mind. These are some of the plants and some of the commonly used vegetables which will affect warfarin. This has to be kept in mind. And there are certain high risk thrombotic events like older generation valves and mechanical valves in the aortic position have low incidence. Other factors like atrial arrhythmias, previous thromboembolism, ventricular dysfunction, these are also high risk. In these patients, they require a higher INR. Patients who have had more than one mechanical valve or right side mechanical valves also are higher risk and they require higher INR. What about patients who present with high INR? If the INR is below 5 and there is no bleeding, this is not an emergency, just omit the next dose and more frequent monitoring. If it is 5 to 10, also again one can omit the next few doses. But if it is more than 10, but if there is no bleeding, one has to give vitamin K. If there is bleeding, we can give fresh frozen plasma. This is the ESC guidelines for excessive anticoagulation who present with the bleeding. So balancing between bleeding and thromboembolic risk is very essential in children. The bridging therapy, because these patients very frequently go for non-cardiac surgery. In patients who have mechanical heart valves and the minor procedures like dental extraction, and this is from adult guidelines, so cataract is mentioned here, but dental extractions, if the minor procedures, the continuation of vitamin K is recommended with a therapeutic INR. Patients who have mechanical AVR and no other risk factors also similar, but who have patients who have mechanical valve prosthesis and require emergency non-cardiac surgery, we have to change over to fresh frozen plasma. And patients who have bioprosthetic valve, this is not important here. No, is already mentioned. For those who have dental surgery with therapeutic levels of INR, can be managed with local hemostatic measures without skipping the oral anticoagulants. Those who develop stroke, any or other form of thromboembolism, those who have mechanical aortic valve replacement, we have to increase from 2.5 to 3 or add aspirin. Those who are having mitral valve also, we increase the INR range, the goal INR, and add aspirin. Those who present with acute mitral aortic valve occlusion, so-called stuck valve, we do imaging, including fluoroscopy, to see the valve function, the valve motion, leaflet motion, and the extent and the size of the thrombus. We can give either slow infusion of 0.5 mg per kg per hour for 6 hours, low dose continuous infusion for 24 hours, or low dose infusion for 48 hours with this recommended dose. And mechanical prosthetic valve thrombosis, urgent emergency replacement is required if the patient is critically ill. Otherwise, the earlier mentioned fibrinolysis can be used. And these are the factors that favor surgery or thrombolysis in patients who are present with acute thrombosis or stuck valve. Postgraduates can just note this. Those who have low surgical risk, those who have recurrent valve thrombosis, readily surgery available with large clots, other concomitant surgery, they favor surgery. When they present with hemolysis or paravalvular leak, these are the indications and the class recommendations. Reoperation if it is related to endocarditis or hemolysis requiring blood transfusions or severe symptoms, class 1. Transcatheter closure if the anatomy is suitable and clinically significant, or there is hemolysis, class 2A. is again similar. Now, eye prophylaxis is a must for all mechanical valves, all prosthetic valves. This is a topic already discussed. Pregnant patients with mechanical valves, so I'm not going into the detail. Thank you.